Alright, we're going to go over some respiratory medications. We are going to start with our bronchodilators or our beta agonists. So if you need a refresher, go back. There's some videos on your alphas and your betas and what they do, the agonist, antagonist, and all the different things that they do within the body. So the big things we're looking at here are your beta adrenergic agonist or your bronchodilators, and they're going to produce bronchodilation. Now, some of these drugs, remember, are selective for just your beta 2s, or they may have an influence on your beta 1s as well. That comes into play when you are deciding, if you have multiple options, which ones to use for your patients. These are commonly used for your obstructive airway diseases, whether it's COPD or asthma, anything like that. Now, some of your more common ones that you may see would be epinephrine, racemic epinephrine, and in a specific case, albuterol and terbutaline are going to be your primary ones there. All right, with your epi, it is a sympathetic agonist, and it is a naturally occurring catecholamine. It will affect your alpha and your beta adrenergic receptor sites, but it does have a more profound effect on your beta receptor sites versus your alphas. Right, now, so remember that it will increase your heart rate, increase your cardiac contractile force, it will increase your systemic vascular resistance, and increase your blood pressure. The main thing we're looking for here is the bronchodilation due to acting on those beta 2 adrenergic receptor sites. Now, it has quite a few indications. It has quite a few dosages and things like that, just depending on how we give it and why we're giving it. So our dosages usually are going to be 0.3 to 0.5 milligrams of 1 to 1,000 IM. You may also give 0.3 to 0.5 of 1 to 1,000 IV. But the epinephrine dosages are going to be based on the weight and the condition while we're giving it. For our pediatrics, 0.01 milligrams per kilogram IM is usually going to be our standard dose, up to a max, usually of 0.3. All right, our 1 to 1,000 should only be given subcutaneous or IM. We do not want to give that IV. You can cause some serious problems there. So as far as our onset duration and whatnot, sub-Q onset's 3 to 10 minutes. So because of that, if you notice with your IM, we're talking 1 to 2 minutes, and your IV, you're talking extraordinarily fast, less than a minute or so. Because of that, we're not really doing as much epinephrine sub-Q anymore. It's primarily given IM or IV now. Peak effects are pretty quick, duration of action, and it lasts for a little while. Your IV's the shortest, your IM's the longest. So important to note there. Now, overall, your indications are going to be bronchial asthma with some kind of bronchospasm, an exacerbation of your COPD, allergic reactions, or anaphylaxis. Now, contraindications. Most of these are going to be kind of a relative contraindication depending on what the situation is. All right. If they have an underlying cardiovascular disease or hypertension, if they have profound anaphylactic reactions and they are peripherally vasoconstricted, you may want to consider IV epi versus your IM just because of absorption there. That's pretty much it. Your precautions. It should be protected from light. It tends to be deactivated by your alkaline solutions. Remember we talked about where your bicarb interacts with almost all of your sympathomimetics, so you want to make sure that you are not mixing it with that if at all possible. And if you are giving them epinephrine, you should be monitoring very carefully for changes in blood pressure, pulse, and EKG, especially any kind of dysrhythmias, tachycardias, things like that. Okay, it can cause palpitations, anxiety, tremulousness. It can cause headache and dizziness, nausea, vomiting. It is going to increase your oxygen demand, so it could cause some ischemia even. So just be very careful with this. As far as interactions, the effects of the epi can be magnified if you have a patient who is also taking an antidepressant. Alright, for your racemic epi. Now, some people kind of are under the misunderstanding that you can just take regular epinephrine and mix it in with some saline and nebulize it and it's now racemic epi, but that's not how it works. Racemic epi is its own drug. It is a sympathetic agonist, and it's a little bit different from your other epinephrine compounds. It's an isomer, which means basically it's almost like a kind of like a mirror image of the epi, so it's chemically a little bit different in structure. It is going to stimulate your alphas and your betas just like regular epi, but it does have a slight preference for your beta 2 adrenergic receptors and causes bronchodilation. It may also relieve a little bit of the edema associated with croup. Onset's pretty fast. Our indications are going to be use it for laryngotracheal bronchitis or croup. Contraindications, we're not going to use it in the management of epiglottitis. Our dose is going to be a 0.25 to 0.75 mLs diluted with 2 milliliters normal saline to give us a 2.25% or 2.25% solution. It's going to be nebulized. We're not going to repeat it. It's just given inhalation one time and you're done. Precautions can give you tachycardia and some dysrhythmias as expected with something that's going to affect the alpha receptor sites. Monitor the vital signs and just be aware that patients may have a rebound development after that initial treatment of the bronchospasm, so just be very careful. They need to be observed very carefully for at least 24 hours, so they need to get transported to the hospital. Now, your next sympathetic agonist, your albuterol. This is a selective beta 2 with very minimal side effects. It's pretty good with your bronchodilation, and it's going to last for several hours. Onset's pretty quick. Duration of action's also a decent amount of time. Our indications here are going to be bronchial asthma or a reversible bronchospasm associated with your chronic bronchitis and emphysema, so your COPD there. All right, your contraindications, if they have a known history of hypersensitivity. Our dose is going to be either a meter dose inhaler or small volume nebulizer. If it's a meter dose inhaler, usually 2 sprays, 2 to 4 depending on what references you look at, with each spray delivering 90 micrograms. Now in a nebulizer, your initial dose is going to be 2.5 milligrams, which would be 0.5 milliliters of a 0.5% solution diluted in 2.5 milliliters of normal saline. You may also see, in some references, that some say for a severe bronchospasm or prolonged bronchospasm, you may want to go ahead and start with 5 milligrams. Do 2 of those. Do 2 of your dosages for albuterol off the gate, depending on, as long as their heart rate is within the acceptable range there. Now your precautions. Vital signs must be monitored. Use caution in those with cardiovascular disease, hypertension, and the elderly. You must auscultate the lung sounds before and after each treatment. Side effects are the same as all the other beta agonists: tremors, arrhythmias, nausea, vomiting, dizziness, hypertension, palpitations, headache. You could have increased side effects if you're giving this with other sympathetic agonists. And if the patient is taking a beta blocker, it may blunt the pharmacological effects, which makes sense because this is going to act on those beta receptor sites. A beta blocker is going to be blocking those beta receptor sites. Now your terbutaline. This is also a sympathetic agonist, but it is a synthetic sympathomimetic. All right? It is selective for beta 2. It's going to cause bronchodilation with minimal cardiac effects. Onset's very similar to epi. It's pretty fast. Interestingly enough, it's actually also used to suppress preterm labor in your pregnant patients. There are actually some beta 2 receptor sites that it responds to in the uterus that helps minimize those uterine contractions as well. All right, like the other ones, vital signs must be monitored. Caution should be used with those with cardiovascular disease, hypertension, and the elderly, and we need to auscultate the lungs after each treatment. Side effects, same as the rest of your sympathomimetics: hypertension, chest pain, nervousness, palpitations, dizziness, anxiety, headache, tremors, arrhythmias. Interactions, same again. When you use it with other sympathetic agonists, side effects increase, and that beta blockers may blunt some of those pharmacological effects as well.